Greetings from Seattle. We are here for the 61st annual meeting of the American Academy of Neurology. My name is Kapil D. Sethi. I'm a professor of neurology and director of the Movement Disorders Clinic at the Medical College of Georgia in Augusta, Georgia. With me here is Dr. John Morgan, who is an associate professor of neurology and director of the National Parkinson Foundation Center of Excellence at the Medical College of Georgia in Augusta, Georgia. John, it's an exciting time here in Seattle. At least it's not pouring rain. Hopefully the weather will stay good when we are indoors attending 8 or 10 hours of the scientific program tomorrow. We have a large number of abstracts and platform presentations being presented, and we're trying to anticipate which ones would be most impactful, which are most interesting for practicing neurologists and other practicing physicians. I have sort of arbitrarily chosen a few, and I'll be asking you a few questions, and you can pitch in anytime, tell me what you think. One of the groups of abstract deals with the introduction of these long-acting dopamine agonists. Pramipexole has probably the most of them in this meeting, and Rupinerol as well has a couple. What do you think of these new studies looking at long-acting dopamine agonists? Are they going to be a meaningful advance in treating Parkinson's disease patients, or is it more of the same?
Well, I think they have potential to help patients by providing a better regimen to adhere to. Once daily is certainly much easier than 3 times a day, so that's one possible benefit for patients and physicians in achieving compliance. Cost is obviously a concern as many of these go generic. Rupinerol is already a generic. So we'll see over time how they work out.
You think they'll have a place for the management of nocturnal symptom in Parkinson's disease? If the symptoms return at 3 in the morning, for example, where your regular immediate acting agent might be out of your bloodstream, out of your brain or whatever, you think the long-acting drugs might have a place in that setting?
Yeah, there was actually a study that we saw here in abstract form that looked at sleep symptoms with Rupinerol ER, and it appeared that it was helpful.
So you can probably predict that Pramipexole ER extended release will probably do the same. Another kind of disappointing thing has been rotigotine. There is an abstract talking about the return of rotigotine patch in the American market. What do you think? Would that be important for our patients to have an alternate way of administering anti-Parkinsonian therapy rather than through the mouth?
I'm not sure yet. I think a once daily formulation, whether it was oral or a patch form, has advantages. And if the oral formulation is as good as the patch, then why have a patch?
Oh, I see. I just have some patients who sort of like the patch, and it's really interesting. Many of them don't want a patch, but there's some they like patch. It's such a big individual variability that I think it's nice to have a choice that we can offer our patients. We got once-a-day pill, we got once-a-day patch. You take a pick. So I think it's good to have a choice. Moving on to the other area that's been of interest is restless leg syndrome. There are several abstracts looking at a gabapentin prodrug. It had a number, now it has a name, but anyway, it's being studied in restless leg syndrome. Well, why do we need a drug for restless leg syndrome? We have dopamine agonists, narcotics, we got benzodiazepines, we got gabapentin. Why do we need another drug?
Well, gabapentin was proven effective in a small study compared to the dopamine agonist Rupinerol. Equally efficacious in one small study. But the data behind gabapentin is relatively lacking, and the bioavailability of that drug is reduced. So maybe this new formulation will give us a better result.
Are there any problems taking dopamine agonists for restless leg syndrome? Over your last 5 to 10 years of your practice, I know you have a lot of experience with dopamine agonists. Are there any problems with long-term use of these agents?
Definitely. It happens more often with levodopa, but with dopamine agonists as well, you can have augmentation and rebound that occur with these drugs. And those aspects of RLS on treatment can certainly make it difficult to where you're dosing more often during the day with dopamine agonists than you may need to with gabapentin. That's possible.
And I think in that setting, the once-a-day dopamine agonist may have an edge also over the immediate release dopamine agonist. There is a poster on rotigotine treatment of severely augmented RLS patients, and rotigotine seems to provide a continuous benefit throughout the day and night, and that would probably be the same with the other dopamine agonists. But you're right, it's another group, doesn't have the dopaminergic side effects that include impulse control disorders, for example. What we see in Parkinson's disease can be seen in restless leg syndrome. And I think another drug, another compound of a different class would be a major advantage. Wouldn't you agree?
Very useful.
And so let's move on to another area of therapeutics. It's exciting time to be in neurology. We can finally do something for our patients, not diagnose and adios. We are actually making a difference. And one of the diseases that I used to run away from, or one of the disorders, is dystonia. Now, focal dystonia, we've made a big difference with botulinum toxins. Won't you agree?
Yes.
Now, we had botulinum toxin A, the Allergan product. It's called Botox, and we've got to use a trade name there to distinguish it from the newer ones. And then we got the B, or Myoblock, which both have been in market for many years. Now, there are abstracts dealing with a new formulation of botulinum toxin A. It's called NT201. Tell us a little bit about that. What did you get out of those abstracts?
Well, it looks like that NT201 is a botulinum toxin A that doesn't have the other complex proteins with it, mostly albumin and a few other things. But this drug actually could be used perhaps in the future more often than every 3 months if it wasn't as immunogenic.
Right, so if somebody's coming back, say, I need injection every 10 weeks, not I can't wait 12. Normally we tell them, no, you have to wait 12 weeks because otherwise you're at a much higher risk of developing antibodies and resistance. This drug may have a place. So that's another exciting compound. Now, there is a move towards treating Parkinson's disease earlier and earlier. As you know, there are trials with rasagiline, Tempo, Adagio was presented in another meeting, but they are presenting some results of Adagio, secondary outcome variables. What's your read on this, the place of MAOB inhibitors in early Parkinson's disease?
Well, I think they certainly have a very good role as a very safe drug to use. We know that now. We also know that the side effect profile is similar to placebo for early patients, which is a good choice. Efficacy-wise, certainly it's not as potent as levodopa or dopamine agonists, but we know from the Tempo and Adagio trials that now starting therapy earlier in Parkinson's disease is probably going to turn into the rule rather than the exception years ago.
Okay, and another thing that we're moving towards is diagnosing preclinical or premotor Parkinson's disease. Are there any abstracts dealing with that in this meeting? For example, looking at carriers of a certain mutation in a certain gene, imaging them and seeing if we can predict who might get Parkinson's in the future?
Yeah, I think there was one on PINK1, if I remember correctly.
Yes, from Germany, yes.
Yeah.
And that's very exciting that the heterozygotes that have very subtle clinical features, they found, have a significant reduction in their dopaminergic imaging markers, which might be a clue to early detection. And maybe we can intervene before the motor symptoms appear one day and treat Parkinson's disease like we treat heart problems.
Yeah, just
before
because
you have a heart attack, you intervene then, don't you think?
Yeah, just because a patient has motor symptoms, Parkinson's probably started years before.
And there are two abstracts. Actually, there's one that I want to particularly talk about. It deals with pathology in essential tremor patients. As you know, essential tremor is most often confused with Parkinson's disease. These patients live a long time, and they're afraid that as they get older, they'll get Parkinson's disease. And there was a study by a New York group that some of them had Lewy body pathology in the locus coeruleus, not in the nigra as much. What about this particular abstract? Why do you think is that important, the one that deals with tyrosine hydroxylase levels in the striatum?
Yeah, the Mayo group actually showed that looking at tyrosine hydroxylase staining in the brains of deceased ET patients, that there wasn't a decrease in the staining for that. So perhaps it's not a precursor of going on to Parkinson's disease despite living with ET for 30 years.
So that would be very reassuring to our essential tremor patients. But this is still a field that requires a lot more intense study, and there's a lot of debate because another poster deals with the fact that there's a 2 to 3 times increase in the incidence of dementia in ET patients. I'm not sure I believe it. These patients live longer, but clearly there is conflicting data, and we have to look forward to seeing some more results.
Yeah.
Thank you. This has been real nice. Thanks, you very much.